Okay, here we go. Time to introduce our fabulous speaker. We're so thrilled to have Dr. Kaitlin Touza here today to speak to us on pain. She is a psychologist and assistant professor at the University of Washington Center for Pain Relief. She provides evidence-based individual and group interventions, including CBT, ACT, EAET, and PRT. She also provides consultation to a broad population in the Pacific Northwest region in Alaska through the University of Washington's TelePain program. Dr. Touza is a fellowship trained in clinical pain psychology. She is passionate about education, outreach, and program development for patients, family members, and healthcare providers with the goal of improving access to specialized multidisciplinary pain management in rural and underserved populations. She believes in patient-centered, evidence-based, and biopsychosocial approach to intervention, program development, and assessment. So with that, I'm going to exit stage left and turn it over to Dr. Touza. Thank you.
Thank you for that intro. And for having me. I'm excited to talk about this. As that intro suggests, this is something that I am passionate about, and I welcome the opportunity to talk about these things. Again, no financial disclosures, but I do want to let people know that I have these beliefs about pain and pain management. All pain is real. All pain is a biopsychosocial experience. The more that patients and healthcare practitioners understand chronic pain, the better outcomes they have. Again, both patient and practitioner outcomes. That hurt does not always equal harm. That pain does always equal protection. That pain is complex, and really everything matters when it comes to chronic pain. And that recovery is possible. I'm going to talk today about some of the benefits and challenges of telebehavioral health in the chronic pain population, some special considerations for working with this population, review a little bit of the evidence for pain psychology delivered via telebehavioral health, and talking about developing a multidisciplinary team, because this is particularly important in management of chronic pain. And then, time permitting, I will talk about some of the basics of pain psychology, a little bit about pain neuroscience education and how to deliver that intervention. And I'm going to give you a whole lot of resources, because even if I had 4 hours instead of 40 minutes, it wouldn't be enough time to really talk through all of that pain neuroscience stuff. So, but I would also be remiss in my role as a pain psychologist to not use every opportunity I have to give a little bit of tidbits about pain neuroscience and pain psychology, because it is not so easy to come by for most of us. So a little bit about the overall burden of chronic pain. We know that overall telehealth utilization has increased, during and post the COVID-19 pandemic, and that increase is also seen in chronic pain populations. But we're also thinking about individual, societal, and healthcare changes that have been imposed by the pandemic. And, essentially we're seeing it exacerbating the burden of chronic pain and more difficulty self-managing chronic pain. We saw new onset chronic pain occurring at a higher rate, closer to 20% of people who had COVID-19 compared to 1.4% of control, so a higher rate of chronic pain incidence in people who have had that disease. And then that also rates of chronic pain appear to increase overall, so not just in people who have had COVID, but during the pandemic, compared to pre-pandemic times. And also that the burden of chronic pain and the intensity of chronic pain may have also increased. And this was shown in multiple studies, including the US. We also know that the pandemic has heavily played into the biopsychosocial model's influence on pain, or our understanding of that model, recognizing that pain catastrophizing and the experience of chronic pain has increased during the pandemic. As we see with this increase, things like social isolation, disconnectedness, more emotional distress, and physical activity restrictions, things like that, uncertainty regarding healthcare may be contributing to some of those increases in pain catastrophizing. But even before the pandemic occurred, chronic pain has been a big problem. High impact chronic pain is something that limits work and limits activity most days. And that's typically thought of as, at least going on for at least 6 months. But, About 1 in 5 adult Americans have chronic pain. That's pain that persists longer than 3 months. And that it's that 8%. So, 1 in 10 are experiencing high impact chronic pain. And it's expensive. It accounts for more healthcare costs and also considering costs related to loss in productivity and disability programs. So more healthcare costs than cancer, heart disease, and diabetes. Big, big problem. And it's one of the most common reasons people seek medical care. We also know that rates of chronic pain are higher in rural communities. And these, people in rural communities are facing less access to specialized healthcare. Health insurance, it might be different in compared to rural settings. Just in general, healthcare services may be less. And so again, further widening this gap, this healthcare disparity between urban and rural areas. And in chronic pain management, specialty trained healthcare practitioners are few and far between in rural areas, if they're there at all. Comprehensive multidisciplinary teams for pain management are likely not achievable with local practitioners. And also, people who are living with chronic pain are likely to also be living with other comorbidities, things that may require more specialty care to address. Medical comorbidities, restrictions in mobility, changes in ability to perform ADLs, things like opioid use and dependence, other substance use, sleep disturbance, and need for specialty sleep medicine is key in this population. Mood changes, anxiety and depression rates are higher. And just in general, all of this stuff, of course, is leading to reduced quality of life. But another concern here is increased risk for suicidality. Telemedicine, including telebehavioral health, brings these specialty and multidisciplinary medical care teams to rural populations, and this is a necessity for effective management of chronic pain. Restrictions in mobility, being able to receive multidisciplinary care without traveling for many hours, without paying for a hotel, those types of things is hugely helpful for these folks. Many people living with chronic pain have taken a hit to their financial health due to changes in work ability or just overall increase in healthcare cost or both. And so beyond the physical burden of travel, which can be quite difficult for people with chronic pain, you have this, increasing financial cost with traveling for medical care that can be prohibitive. Because people managing chronic pain may be seeing multiple providers on an ongoing basis as well, things like FMLA and leave from work time is used up pretty quickly when we're, getting people into the multidisciplinary care that's helpful to them. And so again, using telehealth and telebehavioral health helps to protect clients from this so that they may be able to have a session or an appointment over lunch without having to take time away from work or pay for more childcare. Telehealth is also associated with reduced no-show rates in some specialties, not all, but many, and may be particularly helpful for people who are in socially vulnerable groups, such as low-income, minority, and underserved populations. We see that there is an even improved no-show rate, so an increase in improved no-show rate for people in those populations compared to patients who are in better served areas. And again, for this reason, when we're trying to do large amounts of telemedicine work, we need to think about protecting ourselves from burnout. If we have schedules that were originally set up for a certain amount of expected no-shows and cancellations, and that's not happening anymore, we might need to think about protecting ourselves a little bit if we are, experiencing higher rates of burnout because of the increase in show rates. Of course, we also have the benefit of reducing the risk of infectious exposure and it just being generally more efficient from a time management perspective, reducing that need to room and unroom patients. We do miss out on some things with telebehavioral health, though. One is just the natural behavioral activation coming into an appointment in person. And this may be particularly important in this chronic pain population because people with chronic pain are often not as active outside of their home because of that pain. And so we might want to incorporate some type of behavioral activation outside of session activities that might make up for that. We also might miss out on nonverbal cues, things that are happening off camera, or if we're having an issue with stuttering or frozen video. This can, in my experience, affect things like observation during mindfulness. Patients may have trouble setting their camera up in a way that facilitates adequate observation as well, and that can kind of be awkward and cause a disturbance during session, trying to get that set up. In the home environment or anywhere else somebody might be doing their telebehavioral health, there's also increased distractions and limitations to privacy. Even if somebody is, in a private space at work or at home, somebody might knock on that door if they're in their car, things going on around them, even if they're not directly impacting what they're talking about in session, maybe distracting. If patients are needing a family member to help them to set up their device, that's another thing that might, contribute to privacy concerns as somebody is helping them to get set up for the appointment. Um, and so we want to encourage patients to try their best to have a private space with a door that they're allowed to, that they're able to close, to let people know not to disturb them during the session, so that they have some expectation of quiet, where we can practice something like mindfulness without a distraction. Telemedicine or telebehavioral health also introduces some health equity concerns. Chronic pain is just by nature tends to load more into older ages. And so there may be, considerations for literacy with the device and how comfortable they are using their device for telemedicine. The cost of these devices can also be prohibitive if they don't have a device that's going to host the telemedicine app or platform. That might be, again, another barrier to receiving this care. And again, just as we are having people kind of be able to move mobily through their life, through doing things, that it introduces the opportunity for a violation of privacy. There's also perhaps more potential for miscommunication and risk for misdiagnosis because of that. Patients who are needing communication aids or have different needs for communication might have more difficulty, facilitating that need in a telehealth or telebehavioral visit. And then there's truly very little education on how to work with medical interpreters. I believe in a study that was focused more on medical providers, medical students. The rate was around 20% of specific training in working with a medical interpreter. And so if you add in the layer of telebehavioral health, where we are communicating through a device, that adds perhaps another layer of challenge if we are not understanding how to best work with our medical interpreters. Of course, for all telebehavioral health, we have safety concerns and, the need for the patient to be in a stationary location. They can't be in a moving car or in transit. There is concern, of course, for increased risk for injury or accident in that setting, but also distraction. Even somebody who is not driving that car is not going to necessarily be able to focus into that session the way that we would want them to. And of course, that lack of privacy in those types of settings. We need to also know where the patient is in case for any reason we need to send help to them during the visit. And so again, how would you do that if somebody is moving during the visit? So we need them to stay in one place. We also want to know and document any emergency numbers for that patient's location. Keep those in the chart. I like to put them on the little sticky note that we have in the Epic file so that it's easy to access if I ever need it. We also want to know the location of the nearest ER or urgent care. So if we ever need to point somebody in that direction, we have that information without having to search for it. We want to create a plan for escalation of care and employ shared decision-making with the client to decide when and how to take those steps to escalate care. Having a local emergency contact in telemedicine, I think, is especially important. And again, we'll need a release of information for that person, but creating a plan of when and how to contact that person, who would just be potentially a person in that person's life or a practitioner that they work with, that can help them to establish safety if needed. We want to establish contact with the patient's healthcare team, and again, needing release of information from that so that we can both be updated and update the team on what might be going on in emergency situations. and then a plan for how to handle a disconnection of the telemedicine connection during an emergency. So again, that might rely on something like that local emergency contact so that we have a place to reach out to and establish safety with the patient. And then in the chronic pain population, we need to be perhaps a little bit more concerned about suicidality. Chronic pain is an independent risk factor for suicide. It has a high rate of suicidal ideation in this population, and a large number of suicide deaths involve chronic pain. So it's something that we want to be aware of and concerned about. In my practice, it is highly usual for patients to report passive suicidal ideation focused on escape from pain. So it is a more usual than unusual in my anecdotal experience practicing in this population. And then, not on the slide, but just again, something I'd like to bring up is increased patient acuity during the pandemic and post-pandemic. So this is something that I have heard from colleagues. It's something I've experienced myself. I've seen some sort of qualitative research that again talks about this change where we are noticing that the patients that we work with seem to be more ill. And there is some evidence that shows that people who are in inpatient settings are staying longer and seem to have more signs of acuity, such as more one-to-one observation needs and things like that. While at the same time, during the early part of the pandemic, ER visits for behavioral health reasons had decreased, so people weren't seeking as much emergency medical care. So interesting trends there to pay attention to. Evidence for telebehavioral health has similar outcomes for in-person and for in-person intervention versus the remote intervention. We see improvements in mood symptoms in the pain psychology population as well. So again, it seems to be a good alternative or a good match perhaps to in-person intervention in the chronic pain population. It is, and so this first study was looking mostly at some of these mood related factors, and in the study below they did also look at pain interference, so how much pain is interfering with activity and quality of life factors and things like that, and it does seem to also help with that, so that's good to know. However, there was an interesting pattern of dropout in the second study where they showed more dropout in the telebehavioral health group, which is different than what I've seen in some other telehealth studies. And that seemed to be connected to the level of activity, where people were more likely to drop out of the telebehavioral health intervention if they had lower activity scores at the start, and they were more likely to drop out of the in-person intervention if they had higher activity scores at the start. I'm not quite sure how to make sense of that, but it is interesting. And again, not quite what I'm seeing in all telehealth studies about dropout. Establishing a multidisciplinary team in chronic pain management is really essential. It is really the best evidence-based way to manage chronic pain is to have a multidisciplinary team. And when you're in private practice, that's going to be more challenging and perhaps something that needs to be more effortly taken on than if you're in an academic medical setting like I am, where it's fairly built into the setting that I'm in. And so there might have to be more effort in creating a team around your client and around yourself, really, and see the benefits of that. The treatment team in pain psychology will probably look a little bit different than it might for other behavioral health specialists. There's going to be more medical practitioners, physical therapists, specialty physicians, and specialty psychiatrists that are trained in chronic pain or neurological considerations, rheumatology, all kinds of things are coming into your chronic pain team, integrated medicine. And so, in addition to other behavioral health providers, where you still may also be conferencing with a couples therapist or somebody who's helping with a health behavior change like weight loss, that would be fairly common that somebody would be seeing more than just me on the behavioral health side as well. We also get the chance when we're working in a multidisciplinary team to help patients and providers by limiting this fragmentation of medical care so that we're reducing redundancy, we're improving efficiency in this person's medical management and behavioral health intervention. We're improving safety with regard to factors like polypharmacy and competing medical advice. So again, looking at this as sort of person-centered and holistic, we get that chance to really see this, the whole picture of what this person is engaging with. It also allows us to incorporate some things that we might not necessarily have knowledge of or experience in ourselves. So going beyond the biopsychosocial factors and incorporating things like spiritual, cultural, and other types of healing and engagement. It allows for interdisciplinary decision making so that we are incorporating these different concepts, ideas, and case conceptualizations into how we might approach work with this person. It also allows us and people who are minded in this way, behavioral health providers and other practitioners who are minded in this way, to help to make sure that our patients are receiving trauma-informed care, that we're incorporating inclusivity and affirmation for our LGBTQIA2S+ folks, and that we are thinking about behavior change strategies for people who need different approaches to things. So like our neurodivergent folks that might want a different approach to whatever management strategy we're working on. And so it gives us a chance to help people to incorporate those things into their treatment as well, and ultimately help our clients get the best care they can. It provides information for us to grow as professionals too, especially in chronic pain management. So much is needed on really understanding some of the healthcare and other types of intervention that our clients might be going through, where if you don't have that type of training, if you're not exposed to those, ongoing sort of grand rounds and things like that, where people are talking about these different chronic pain management topics, we might not get all of that information. And so it gives us a chance to develop professionally by understanding this chronic pain world and treatments and the science behind what people are doing. And also, we want to keep meetings regular and communication easy and facilitated, because we don't want this to be another thing that is overwhelming our schedule. We want it to be built into what we're doing. And what I, not being in private practice myself, but learning from some of my colleagues that are, incorporating the cost of those meetings and the time spent on that coordination in the fee that we charge for services, so that it is, our time there is accounted for and valued. In service of building a multidisciplinary team, I want to talk about TelePain and the opioid hotline. TelePain is a free weekly service that is intended to increase knowledge and confidence in chronic pain management. Every week, you get didactic education and presentations from experts in the field. You get a chance for case consultation with a panel of interprofessional specialists. And ultimately, you get a greater sense of what the challenges are in managing chronic pain. That group has, anesthesiology and pain medicine specialists. We have pain psychiatry, pain psychology, rehab medicine, family medicine, integrated medicine. We have quite a panel of experts there. So you get a wide range of education in chronic pain, as well as, potential for consultation from specific experts. That is geared toward the primary care or family medicine provider. And so the people who are presenting cases are typically going to be a PCP or a family medicine provider. That being said, all are welcome. All are welcome to join and to learn in TelePain. And so, and even if you're not the one, if you're kind of coming from a behavioral medicine perspective and you're listening to somebody who's coming in as a primary care to talk about their case, you're going to hear from the behavioral medicine perspective as we go over that case. So you'll get some of that education on that side as well. The opioid hotline is another fantastic free resource. It's clinical advice for healthcare providers caring for patients with complex pain medicine regimens, especially but not exclusive to high-dose opioids. It's staffed by a pain medicine physician and clinical pharmacist who's a pain specialist as well, or an opioid specialist as well. We want to make sure that people know that the information is, geared perhaps a little bit more toward Washington and Alaska, but we're happy to discuss questions from any provider, and the topics are not state specific. So again, if you're coming from a different state, I wouldn't let that hold you back. We do need to make sure that this is framed as educational consults only and does not, assume care at any level or establish provider-patient relationships. It does, we're not providing actual treatment plans or changes. any decision about patient care is ultimately the purview of the provider who is giving care to the patient. This conferencing gives you the opportunity to see and potentially connect with other providers who are managing chronic pain, people who are in the audience, people who are presenting, people on the panel. It starts to maybe give you an idea of where people are, who you might connect with. You might get a sense of who shares similar philosophies in patient care, that as you hear people talk and ask questions, and you might get a sense of who you might want to reach out to in that case. You're also going to get every week relevant resources for management of chronic pain and other related concerns. So, managing to get through this in a reasonable amount of time so we can spend a little bit of time talking about pain psychology and some considerations in this population. So, big picture pain psychology is a brief intervention. It is focused on building self-management skills, improving self-efficacy in our management of pain and how we feel about managing pain, and engagement with meaningful activities. It focuses on education, so understanding what's going on in the nervous system, the brain and body connection, understanding what factors influence pain. And pain neuroscience education in and of itself is an intervention because it helps to reduce fear avoidance, and it helps to change our sort of threat appraisal process when it comes to the pain we're experiencing. You're going to have mindfulness strategies, which, I always say, no matter what type of therapy modality you're doing, you're employing mindfulness, because you cannot sense into your thoughts and know what you're thinking and why you're reacting to something if you don't have some ability to be mindful of that. So I would say mindfulness and cognitive strategies are, two sides of the same coin. But whatever type of therapy modality you're employing within chronic pain, you're going to address cognitive coping factors, cognitive factors related to threat appraisal and learned fear reactions to pain. You're going to work on developing self-soothing skills and reduce distress associated with pain, sort of decoupling the emotional response with the sensory experience. Activity pacing and desensitization are some behavioral strategies that we use to increase activity tolerance and essentially teach your nervous system that it's okay to move, that it's safe to move, and we don't have to get these pain warning signals all the time. And within that, that'll help with behavioral activation, increasing engagement with meaningful activities, potentially addressing some of the mood and sleep concerns as a fringe benefit of increasing these behavioral, doing these different behaviors and changing the way we engage with activity. Pain-informed physical therapists are often going to be doing a lot of this behavior-related work as well, because they incorporate it into their approach to physical therapy, things like pacing and desensitization, rather than what you might think of as a more traditional type of physical therapy, which is perhaps a little bit more focused on function and strength. Goal setting is a huge part of what we do when we're working with pain psychology. Within pain psychology, it's the first step in assessing our clients with chronic pain and understanding, what they want to see change in their life, how pain is impacting their life, and ultimately learning skills that will help to increase engagement with those things that are meaningful, improve quality of life, and in that process start to build self-efficacy as we start to see that things can change and we're able to desensitize and do more. We feel more confident in our ability to deal with whatever is going on. But that's sort of what you might think of as maybe the skill-focused, activity-focused side of pain psychology. Often, to get to a place where we're able to self-soothe and get our nervous system to recognize that we don't have to keep paying attention to this pain, and what I say next will hopefully make that make more sense. We need to also think about other factors that might contribute to their stress response system. A significant amount of trauma exposure, ACEs in childhood, ongoing current stress, a major physical trauma, these different things that teach our nervous system to pay more attention to danger and to be more ready for it, to be perhaps more hypervigilant to it. These also are going to be driving our awareness of pain, because pain is also a danger signal. And so just like a trauma exposure might increase our reaction to stress and feel it more strongly, more intensely, the same thing can happen with our awareness of pain because of the way that our brain is wired when it comes to danger awareness. And so in order to get to a place where we're able to self-soothe, where we're able to decouple that pain from distress and kind of feel those things perhaps as not the same all the time. We might have to address things like historical sources of stress, like trauma, understanding the trauma system and how that ultimately, contributes to different physical sensations and reactions to those. Learning perhaps self-soothing skills that go beyond pain and into a deeper place where people are, kind of think of what's fueling that reaction style can be part of it. And that's also, can extend the amount of time that somebody is spending in pain psychology. But it's also a reason why it's especially important to partner with other providers, other behavioral health providers, and other providers that the patient is seeing, so that we can get people in with experts on trauma psychology, or experts on distress tolerance and distress management, or anxiety specialists, OCD specialists. We might need somebody to see a different type of specialist before they fully engage in pain psychology, so that we can learn some distress management strategies that go, outside of the sensory awareness stuff and into more of that overall danger alarm system. Here are some of the treatment modalities that have been studied in pain psychology. This is not an exhaustive list, but this is, some of the ones that come up more often. Really, the most evidence is in cognitive behavioral therapy, acceptance and commitment therapy, and mindfulness-based stress reduction. That's where the vast majority of the research has been done, and really CBT more than anything. Those three really do not seem to be superior to each other. They all seem to help. And they all seem to help at fairly equivalent levels. There may be some evidence, newer evidence, that pain reprocessing therapy and emotional awareness and expression therapy is a little bit more useful for primary pain conditions or nociplastic pain conditions. But again, it's pretty equivalent, and catastrophizing seems to be particularly important to address when it comes to benefit from pain psychology. So our danger-related thoughts about pain seem to be important as far as addressing those to predict future benefit from pain psychology. Pain neuroscience education is part of any pain psychology intervention, and it is, again, an intervention in and of itself. Simply doing a pain neuroscience education intervention helps to change the way that people are experiencing their pain. These are some of the elements that are important in pain psychology. We want to make sure that people recognize that pain is complex, and there's likely to be many things that are influencing our pain experience. There's also many things we can use to influence it ourselves because of that. That we are all bioplastic, meaning your brain is changing all the time, and you can change it just like it changes when you're in pain. You can also change it in other directions that are helpful for pain. Pain is not an accurate marker of tissue state. It's actually fairly poorly correlated with tissue damage or severity of tissue damage. So pain and tissue damage, really not the best kind of partnership. Pain education is treatment. I've said that. Pain is a brain output, just like being hungry or being thirsty or being sleepy. Your brain is producing this experience, just like vision. We want to make sure people recognize things like your eyes don't see. They're receptors of light. Your brain sees, and that's what we want to think about pain as well. It's your body does not feel pain. Your brain feels pain. That doesn't mean it isn't real. Just the same way vision is real, so is the pain. Pain is a protective mechanism. It helps us to stay safe, and we can become overprotected or oversensitized. So knowing that our pain system can be overreactive. You want to think about pain as this perceptual experience that is produced by the brain to draw our attention to danger. It may or may not be associated with tissue damage. Its purpose is to get our attention and act so that we avoid danger, which may be not stepping on your injured ankle, or it may be going in from the cold so that you don't get frostbite, because you're going to feel that pain in your toes way before frostbite shows up. So that's what I mean by it being something that may not be associated with ongoing tissue damage. It's also a warning system in that way. It's also a learning mechanism. We only need one exposure to something painful for our nervous system to change how it responds in that context, and potentially be more reactive in that context, so that we notice pain as more intense or more immediate when we're in that context the next time. Because our nervous system's job is to keep us alive, it is a danger and error detecting machine. And so we are better at paying attention to things like pain than we are things that feel good. And so we notice it. We will notice it right away. You want to think about pain like the fire alarm and not the fire itself. So it is not the danger itself. It is an indication that danger may have occurred or will occur if we don't change our behavior. So knowing this can help people to kind of maybe make some sense of the fluctuations in their own pain experience. And real quick, because we're running out of time here, I'll just say that, when we're talking about pain and pain signals in our nervous system, what we're really talking about is nociceptor signals. This is a neuron that picks up on tissue damage having occurred or the potential for tissue damage if we don't change what we're doing. Sends information up into the spinal cord and then up into our brain, where processing is occurring at both the spinal cord and the brain level. We also have a descending neuron loop that comes back into our spinal cord and modulates the transmission of sensory information between brain and body. So essentially, as it goes from our tissues into our central nervous system and up into our brain, we have a downward loop that's going to affect that transmission and either reduce our awareness of something or increase it, so it becomes louder and harder to ignore. Inflammation is going to be working at all levels here to increase sensitivity. What I mean by increasing sensitivity is that your nociceptors need less information to activate, so it's easier to activate them at a lower level of stimulation. And at the brain level, your brain is better at picking up on and highlighting those sensory experiences into our awareness so that we notice them more. And ultimately, we need less stimulation to notice, and our brain is going to amplify it once it gets there. So that is sensitization at both the peripheral and central nervous system level. The reason why there's so many things that influence pain is because the same parts of our brain that are responsible for things like enjoyment, emotions, memory formation, threat appraisal, learning behaviors associated with threat, self-regulation and self-awareness, planned behavior, motivation, the endogenous opioid system and all of its things like social function and bonding, attention and focus, enjoyment, positive emotions, intrinsic motivation and reward, all of that stuff is the same parts of the brain that are responsible for processing pain. So it is subjective and modifiable just in the same way something like attention and focus is. So all of these different things can influence our experience of pain, and this is why pain is whatever a person says it is. It is individual, it is subjective, and it is tailored to each person's experience and history of their own body and emotional experiences. But it's also why we can use things like increasing positive social engagement or changing the way that we think about our pain or our body or improving confidence in self. All of these things ultimately can help with pain because the way that our pain is processed, it's complex and it has all those moving pieces. This is stuff that you already know how to do. So I would just say that, cognitive behavioral theory easily incorporates pain into it. When you think about the way that pain might influence thinking and emotions and behaviors, and then how behavior, emotion, and thinking will flow back into influence our experience of pain. These are concepts that if we can understand pain neuroscience, we can apply our knowledge of the type of behavioral health that we already practice and incorporate pain neuroscience into it, because it is things like, classical and operant conditioning when it comes to learned pain reactions, as well as extinction learning. The same stuff that you do with things like phobia exposures, you are doing for desensitization. It's just that you're doing it with more of a movement or activity versus a feared object. And so you know how to do this stuff. It's the same concept of exposure and response inhibition, self-soothing in the presence of a stressor, challenging the way that we think about something, addressing, catastrophizing, building confidence, engaging in meaningful activities. We're doing all of the same stuff. We're just incorporating some of this knowledge about pain neuroscience into it so that we're, in mind. We have that pain system in mind in the way that we're conceptualizing some of the other things somebody might be going through. So resources now, because again, that was certainly not enough to help us really truly understand pain. Just a couple tidbits that help get people interested. Look for manuals. There's so many self-help manuals out there for patients, and these are actually really wonderful for us to read as clinicians as well, because you get good ideas for how to explain things to people. And if you find the use of metaphor is helpful, which is, I think, hugely helpful in helping people understand pain, this one right here, Painful Yarns, is fantastic. It is going to help you have metaphors you can share with your patients. It has images, lots of helpful stuff. These are some more perhaps emotion focused, experience focused, mindful focused resources that are also helpful for people and have maybe taken more of an emotional approach to the pain management side of things. Um, Podcasts, hugely helpful for both the patient and us. I like to give homework listening to a podcast. Instead of reading something, listen to this podcast about pain neuroscience. I find that people are much more willing to do it. And ultimately, it facilitates more discussion than when somebody's reading something. So use podcasts both for your own education and your patients. Sexual function changes are very common in chronic pain as well as other chronic illness. It's a good idea to have a couple resources there so you can counsel patients about what might be helpful to look into. So many websites out there for both patients and providers, more and more too, as this chronic pain management stuff is getting out there and people are sort of, it's in more people's minds and the problem and the scale of the pain problem is out there. Websites, resources, these all have great resources both for providers and patients. And so we want to point people towards these. We want to explore them ourselves. We don't need to reinvent the wheel. If you have a non-English speaking client, unfortunately, this is where a lot of work needs to be done. There is not a lot of online resources for non-English speakers, but here's a couple that have some pain neuroscience education and tools that you can utilize. I have found many self-help manuals are translated, so that's a good place to go if you are needing tools for somebody who is non-English speaking. Again, I like to give video recommendations for people so they're more likely to engage with it than they are a reading resource. So we give people some tools on YouTube, ask them to watch some of this stuff and come back and discuss it. Lots of phone apps, some specific for pain, others just for kind of meditation and things like that. We also want to use apps for health and mood tracking because there's often a lot of health behavior change we're asking people to do when they're engaging with pain psychology. And then more pain neuroscience education resources for providers. So if you are wanting to further dive into pain neuroscience, you have some places to go and some more resources for pain neuroscience training for providers.
Yeah.
Yeah, so I was looking at the questions and I just responded to one that I didn't know the answer to, but I'll kind of go down the list. First question, are there data separating suicidal ideation due to pain itself versus loss or fear of loss of pain medication, in particular opioids? I don't know the rates of that. I couldn't just recall that on the top of my head, but I know that when we are forced tapering opioids, when patients don't have agency in the choice to do that or the way that it's done, the quickness that it's done, the setting that it's done in, all of that, that it is associated with more, risk for adverse mental health outcomes, mood and things like that. I do believe it carries some risk for suicide, but I don't want to say that for sure because I got to look back at the data and know what it actually says. But it's certainly not something that I would advocate for forced tapering. I think it is a violation of patient agency. Next question, do you happen to know if insurance pays for communication and consultation with multidisciplinary team members to support a patient? I know that it does for physicians. I don't know that it does for behavioral health providers. I have not seen that type of coding. I see my physician colleagues use that and also use things like, complex patient coding and things like that I don't believe are available to us, but I could be wrong about that. Again, I'm not quite as much of an expert in the billing and coding as I'd like to be. Is EMDR used in this area or used in pain psychology? In a perhaps non-evidenced way, I would say yes. I find EMDR hugely helpful in decoupling distress from sensory exposures or internal behavior exposures, whether it's a trauma-related memory or cue, or it's something like encountering something like having a procedure done that has been very painful and we have a lot of anxiety about doing it. There's a lot of health-related trauma and anxiety in this population where even doing something like going to the ER when it's needed, when there's an emergency, it may be avoided because of the amount of negative experiences that somebody might have had in that setting while seeking care for chronic pain. Chronic pain is not a medical emergency in a lot of, and when it's kind of viewed in a triage sense. And so it tends to be a place that people have quite a bad experience seeking care for pain, not always, but often. And so I think EMDR is hugely helpful in getting that stress reaction to reduce so that we can do some more effective desensitization work in pain. So whether it's trauma related, that's outside of medical and pain, or it's pain specific related, or it's pain, trauma, and medical trauma related. Yes, I like EMDR. I think it is a great tool for these patients. Any resources about pain management for children or adolescents? I don't know. That would be a good one. I mean, I know they're out there, but I don't know them myself. Seattle Children's has a fantastic chronic pain management program for children and adolescents. So I would look at their website or kind of some of the maybe talks that are coming out of that, that institution and that department there, the anesthesiology department, to see what you could get, because I know they have them and they're the experts on it. What specific modifications do you implement for CRPS? Thank you for that question, David. That is a great question. CRPS is something that requires perhaps some different approaches that a typical chronic pain condition might. Because CRPS, that's like the nervous system acting as if that part of the body is still actively injured, as if that bone is still broken, and that person has all of the symptoms that would go along with that, from swelling, edema, temperature changes, extremely heightened sensitivity to touch and movement, loss of motor control, all kinds of stuff going on. And so that incorporates things that are unique to that to that condition that needs specific therapy approaches. And a lot of it is done with physical therapy, things like graded motor imagery, mirror therapy, touch desensitization. These really need to be incorporated into a CRPS management plan. And that's not really something that we are often doing as behavioral medicine providers. And so we want to, it's hard to find them, but we need them. They're like diamonds in the sand, these, chronic pain trained physical therapy providers. You can help with the touch desensitization stuff, because when you're doing touch desensitization, you're essentially touching the skin very gently with something very soft, like silk or a feather, and you escalate into more difficult things to touch with. But at the same time somebody's doing that, they need to be mindfully calm. They need to keep their body calm, their muscles relaxed, their mind calm. Because if you're doing that touch desensitization and the whole time you're like, this hurts so bad, I just have to get through it. I have to get through it. That's not going to teach your nervous system that it is safe to touch there, because that's really what we're teaching it. It's safe. There's nothing wrong here. And then we have to do it with calmness, with calm body, calm mind. And so we can really help to teach people skills to be able to do that effectively. And Kara, if you see any questions I'm missing that you say, well, let's get this one, because I'm just going down the list. These are all good questions in my opinion.
Go for it.
How do you counsel around when to seek assistance for potential actual tissue damage or other injury when working with chronic pain? Absolute great question. Thank you, Kyla. What I've heard from my physician colleagues, I think, is the advice that I typically give. Is it different? Is it new? If it's different or new, we need to assess it. If it is the same chronic pain pattern that we have had and we have had assessed, then we don't probably need to assess it. If you're in doubt, assess it. I would never encourage somebody to avoid seeking medical care because they're, not sure if it's that chronic pain or a new thing. I also like to take the common sense approach of just, if you didn't have chronic pain and you had that symptom, would you go to the doctor? Would you get it checked out? And if the answer is yes, you should get it checked out. We don't want to use the same techniques for chronic pain that we do for acute pain, because it's not necessarily safe or, indicated. Next one, taking on a client with chronic pain sounds like a huge commitment and a good amount of additional responsibility and should not be taken lightly. Any thoughts on this? Sandy, thank you. I would say that you are not going to avoid taking on a patient with chronic pain. It is too big of a problem and it's too common of a problem. And so whether in any field that we practice, even child psychology, where the rates are so much lower, In any field, in any specialty, we are going to encounter patients with chronic pain because it is so common. And so, even if you are not necessarily taking on the responsibility of treating that chronic pain, if that's not necessarily where you are specialize or where your true passion lies, just knowing how chronic pain will contribute to what you are working with will help you, will help the client, right? So that's why I harp on learning pain neuroscience, because it, even if you never take on chronic pain as the primary, treatment goal, you'll still benefit from understanding it because you're going to come across these patients. And then there's a question about CEUs that I don't know the answer to. Um, as someone trained in PRT, that's pain reprocessing therapy, which mostly focuses on neuroplastic pain, how do you help with pacing, desensitization, and safety messages for someone whose pain has a structural component? I am not an MD. I do not always know the activities that are safe or not. Well, first of all, I would say get that question answered by somebody who does know that. I always say that. I am a PhD. I am not an MD. I am not a PT. I don't have the knowledge and skills to assess for safety. And that patient is going to believe that a whole lot more if it comes from somebody who does. So even if I think I know and I'd say, I'm pretty sure that you're okay, I still want that patient to hear it from a medical practitioner because that's where they're really going to get that, they're going to believe it. And then we can work with that knowledge and feel confident. I'm sorry I didn't answer all of your question. We're out of time.
We are out of time, and thank you. Boy, you really moved through those very quickly. So thank you very much. Thanks everybody for joining us. We look forward to seeing you next month. I think I will invite you, if you have other questions about pain management, to join the telepain sessions. And I did put or Mylan put the links in to the chat. So we invite you to join those. It's a not a webinar, it's a meeting. So it's very interactive and you're able to have discussions with the panelists and with other folks on the call. So if you didn't get your questions answered, please join there. And Kaitlin is an occasional or frequent presenter there as well. So thanks again, everybody. Have a lovely weekend, and we will see you next month. Bye-bye.